Okay, so I'm going to hand off to the moderator for our next session, who will introduce our next speaker, Dr. John Drover.
Thanks, Robin. I'm John Drover. I'm an intensivist in Kingston. Well, my role here today is member of the board for PSI and a few other parts of PSI as well. So I'm pleased to introduce Dr. Nav Persaud from Unity Health in Toronto, speaking on the topic of patient and family integration. As the Canada Research Chair in Health Justice, Dr. Persaud's research focuses on health equity, namely medicine access and narrowing the gap between low and high income to ensure everyone in Canada can afford the medication they need. Dr. Persaud is also a staff physician in the Department of Family and Community Medicine at Unity Health Toronto, associate professor at the University of Toronto. He's named one of Canada's top 40 under 40 in 2017 and leading the first ever trial providing people with free access to essential medicines, quantifying the links between medication cost and health outcomes. Dr. Persaud was named as a PSI Graham Farquharson Knowledge Translation Fellow from PSI in 2016. So please welcome Dr. Persaud.
Thank you very much for that really kind and generous introduction. I got to update that bio. I'm not under 40 anymore. It's really great to be here with all of you, and I really appreciate all the support I've received from PSI and the opportunity to share and learn from you today. I'm going to talk about patient and family integration by introducing an example of how we engaged patients and community members to design and conduct a trial related to medication access. And after that, I'll make some general reflections on patient and family integration in the research enterprise at different stages, and I'll really look forward to the discussion. Don't have any industry funding to disclose, often because the project I'm talking about is related to providing people with free access to medicines. People usually assume that it's funded by a drug company, so I provide this disclosure up front, and then usually at the end someone says, so wait, what drug company funded this? And we can show the slide again if you like. PSI didn't cover my travel here. It's a walking distance from my home, actually, so I was really pleased to be here. I'm looking at them now and realizing I could maybe do with a new pair of shoes, so I can follow up with you guys afterwards about that. Canada is the only high-income country in the world where publicly funded health care does not include access to medicines, including life-saving medicines like insulin. So we have people who might be admitted and readmitted to hospital because they can't afford highly effective medications like insulin for diabetes. We wanted to engage with this issue by doing research, and we, at the time, to be perfectly honest, didn't know a lot about engaging with patients and community members in research, and there was a particular funding call from the Ontario SPORE Support Unit. SPORE stands for Supporting Patient-Oriented Research, and they required you to engage with patients. And I was saying earlier that we were required to do this in the beginning and maybe started out as a sort of, we got to check the box of engaging patients. And through the process, I came to appreciate the real importance of engaging with people. And the first question we asked was whether or not research is really going to be important in this issue or not. And so we sort of canvassed the area around St. Michael's Hospital, including this area actually, and our students, who you see, two of whom you see pictured there, and the rest of the team wore t-shirts that said free medicines, ? And then we were handing out a pamphlet where people could get information about what we were planning to do and opine about whether or not it was something where doing more research would be helpful or not. And one of the streets we walked down was George Street, which is not far from here. It's estimated to be one of the streets in North America with the highest turnover of illicit drugs being sold and bought there. And when we had the t-shirts that said free medicines, some of the characters who frequent George Street wondered if we were going to be undercutting them in terms of their business, and we had to reassure them that marijuana was not one of the medicines that we were going to be providing for free as part of the study. So prior to starting any study, we actually met for almost a year with a community guidance panel. We were meeting monthly or every 2 weeks to think about whether or not this was a topic that had already been studied too much, or if there was something that we could do, and if so, what. And we ended up co-designing a clinical trial where this panel, including researchers and community members, met to design an intervention and to develop the outcomes for this clinical trial. And part of it was creating a list of medicines that we thought would meet important health needs. We developed a process for developing that list that involved suggestions from patients, suggestions from clinicians, reviews of commonly prescribed medications, and that was the initial part of designing the intervention, was deciding which were the most important medicines to provide as part of the study intervention. And it was, to some people, a surprisingly short list of medicines. Depending on how you define a medicine, there's around 130 medicines. And based on nationally representative surveys of the medicines being prescribed in Canada, we would estimate that it would cover around 80 to 90% of prescribing, if you consider, for example, ramipril equivalent to lisinopril. So the trial we designed was to take people who reported not taking a medicine as instructed because of the cost in the last 12 months to either continue receiving their same usual poor access to medicines or to get free access to medicines, and then we measured their adherence, healthcare utilization, and other measures of well-being. The people included in the study are largely people who work in low-wage jobs, factory workers, taxi drivers, so they don't qualify for social assistance. They're not ODSP or OW recipients, so they don't have access to publicly funded medicines, and they don't have private insurance, part of this job. They also have an income that's low and might be variable in the case of a taxi driver, so some months they might be able to afford medicines and other months not. And what we found after 2 years was in the primary outcome of adherence to appropriately prescribed medicines, there was a statistically significant increase in adherence. The largest benefit that we registered in the study was not in adherence or in a clinical outcome, but in the ability to make ends meet or afford basic necessities without incurring debt. That was an outcome that was suggested by patients at the very beginning of the study, and it was not an outcome that I would have thought of in a clinical trial of providing people with access to medicines. You know, the outcomes that I thought of and the other clinicians and researchers on the panel thought of were A1C, control of diabetes, control of blood pressure, hospitalizations, those sorts of things. But the largest benefit was in the ability to make ends meet. And that's noteworthy because in many situations, in the typical situation in this study, the total medication cost per month would be around $30 to $50. So just eliminating a cost of $30 to $50 could be the difference between someone being able to make ends meet or not. We also showed, when we got some additional funding to extend the study to 3 years, that there was a substantial reduction in total healthcare costs in people who got free access to medicines versus those who had their usual poor access to medicines. The largest cost among participants, as you might imagine, was related to hospitalizations. So there were some patients in the control group, for example, who had type 1 diabetes, and they would be repeatedly admitted and readmitted because of poor control of diabetes, because they couldn't afford insulin. And they would typically, from the hospital supply, be given a box of insulin when they went home, and then when it ran out, they would be admitted, sometimes to the ward, sometimes to the ICU. We've also done some health economics work, sort of estimate how much would be saved if this were to become a policy and medicines were to be publicly funded across Canada. And this is looking just at the cost of drugs that would be less if there were bulk purchases and negotiations that are done by other countries, including smaller countries like New Zealand. And overall, the savings would be around $3 billion per year. That's excluding any savings related to reductions in hospitalizations or healthcare utilization in general. But it would involve additional public outlays of money. And so the way that you save money is by reducing the private spending, including out-of-pocket spending and spending through private insurance programs. I'll just highlight, one qualitative study we did was aimed at trying to understand the experience of people, either who could afford medicines or not. And this was really a study designed and conducted with our community guidance panel, patients and family members. So this is a concept mapping study where we had participants in the study, conducted interviews with them, and then we abstracted information about the themes that they were discussing. We sorted those themes with a panel of people, including patients and family members and researchers. And basically the effects of the intervention of providing people with free access to medicines, there's sort of adherence in the middle that is linked both to well-being. So people talked about sort of the stress of knowing that, being told when you go to your doctor that if you don't take your diabetes medicines, you might have an amputation, you might go blind, and then going home and not being able to afford them, or going to the pharmacy, being told the cost, and then saying, I'm going to come back and get that later, but knowing that you won't be able to afford it later. So there's that stress of being non-adherent. There was also obviously the impact on personal finances, and people talked about either sacrificing other essentials like food, or putting it the opposite way, people talking about not buying their medicines because they prefer to purchase food for their children. Patients and family members also suggested that aside from the study, that we make short films about the experiences of people. And if you want to see a few examples of those, you can go to the study website, cleanmeds.ca, where, for example, one of the participants at one of our rural sites talks about being able to work on his farm for longer when he has access to his puffers. One of the things that the community guidance panel, the patients and family members, underscored to us was the importance of informing a policy change through our work. And I remember in some of the early discussions where we were talking about the policy gap in Canada, the community members said, so at the end of the study, we're going to change the policy, right? And then I said, well, we're just going to do the study. I'm just a researcher. We write the paper. Hopefully somebody reads it. And then the community members said, well, wait, why are we meeting here every month, spending 2 hours talking about the study? We were applying for these grants of millions of dollars. And at the end of it, you're just going to write an article and hope that somebody reads it. They hold us to account in terms of, asking people to participate in a study, have blood work done, participate in interviews for what? And these are people who are having trouble making ends meet. Ultimately, this is supposed to make a difference. So part of the process was meeting with decision makers, and we actually met with some senior decision makers, mostly at the provincial level, but some at the federal level and the municipal levels as well, including prior to starting the project. And then we've built on those relationships throughout the knowledge exchange continuum. And where we are right now is, there is this conference and supply agreement between the Federal Liberal Party and the NDP. It says that by the end of this year, the government is supposed to pass legislation about pharmacare, and it includes some specific language about a formulary of essential medicines. And some of the reports talk about the list that we created as a potential model or starting point. So I'll end off now, before we open up to discussion, with just a few quick reflections on patient engagement. One of the questions I sometimes get is, how do you know if patient engagement has succeeded or if it's been successful? And I think there are a number of potential responses, but I think one of the main ones is to judge patient-engaged research by the same standards as we would judge other research. The purpose of research, I think, is to create generalizable knowledge, and the reason that we do it is because we're trying to improve things. We're trying to improve clinical practice, we're trying to improve policy, and so I think if we're wondering if patient-engaged research has been successful, we should ask if it has achieved its purpose or not. My focus is on health equity and making access to care, access to medicines, more equitable and fair. I just also want to mention that when we're talking about engaging with patients and family members in research, there's the potential to exacerbate inequities depending on how the engagement is done and who is engaged. And saying that a research project has involved patients doesn't mean that it was done well, or that research project is going to lead to results that are more valid than ones that have not. And there's the potential that you could engage people in a way that is sort of the checkbox approach that I mentioned at the beginning, and that I think I have some awareness of, and that could end up just sort of using people, wasting their time, and being worse than not having engaged people. The final reflection I'll share is that engaging with people, it takes time, it takes resources, but it has also been one of the most rewarding aspects of doing research, partly because it keeps you focused on why you started doing research in the first place. As a researcher, you have this idea that you're going to try and make the world a better place by doing research, and then you come against the reality of trying to do research, trying to get funding, trying to get this thing through the REB. Because research takes so long, and it takes so long to change practice or change policy, you can become fixated on these intermediate goals that are not important, like getting a paper published in this particular journal, or getting this amount of grant funding, getting this award. And I think, patients and family members who engage in the research project don't really care about that stuff, and so they can help to keep you focused on what is really important. I wouldn't represent myself as someone who is in a good place to provide others with advice, but I have been part of some groups that are now providing some guidance on how to perform research that might promote health equity. And one part of that is on how to engage patients and family members appropriately. So the Ontario Spore Support Unit has created an equity framework. There's also an online course that you can take, and it's about promoting health equity through research. One part of it is how to engage with patients appropriately. So if you're interested in learning more, you could consult the OSSU website at osssu.ca. I'll just close off by saying thank you again to PSI for all of the support over the years. This trial that I was talking about was done when I was supported by the Graham Farquharson Knowledge Translation Fellowship. I'm very grateful. It came at a very important juncture in my career when I didn't have another source of salary support, and I've received additional funding for other projects led by me and by others through PSI. One is related to access to healthy foods, which actually came out of the same project I was talking about. So in one of the qualitative studies, some of the people with type 2 diabetes said, one less source of stress for me is that I no longer have to worry about affording my medicines, but I'm still aware that I am consuming foods that are not healthy. I'm going to the food bank, eating canned pasta, and I'm meeting with the dietitian, and they're telling me that's not what I should be eating. And so we're now doing a clinical trial of providing people with type 2 diabetes with access to healthy foods, and we're measuring the effect. And of course, we're engaging patients and family members, including some who were part of the community guidance panel for the Clean Med study. It's also really great to have been able to attend other PSI events, including this one, and I really appreciate being part of the PSI community. Also grateful to other sources of funding and support for the project, and looking forward to the discussion. So thanks for both questions. If you look at other clinical trials of interventions aimed at improving adherence, few of them would see an absolute increase of 10%. Whether or not a patient takes a medication depends on a number of factors, including whether or not the patient believes that the medication is going to be helpful, depends on the relationship they have with the prescriber, and to the point of the study, it also depends on whether or not they can afford it. So we addressed several of the reasons that people might not take medicines, but we certainly didn't address all of them. There are many examples of patients who would not really have benefited from our intervention. For example, we had patients who were living in shelters, and they would report that their medications were lost or stolen when their other items, possessions, were lost and stolen. And we would try to replace medicines, etc. But you can understand why people experiencing a variety of disadvantages would not necessarily improve their adherence. Some people had poor connections with their primary care provider, wouldn't return for prescriptions to be repeated. Those sorts of things were sort of beyond the effect of our intervention. So I think in the medicine adherence literature, this is actually one of the biggest benefits. And actually, I remember one peer reviewer being sort of suspicious of the results because the benefit was so large to his eyes. And then your second question was the number on the panel. Yeah, I don't think there's a magic number. I think one of the issues is how can you conduct a meaningful conversation if people are really going to be involved? So our panel, I think at its maximum, would have 12 people meeting. When you're having 12 people meeting, and we try to, when we're discussing each topic, have each person express a view before we would move on, when we're making a decision about an important part of the study. And I think if you get beyond 10 or 12, then it's sort of hard, and you feel like you're maybe sort of giving a lecture as opposed to having a discussion. Yeah, we wouldn't claim that the panel would be representative of everyone in Canada or in Ontario. Certainly it was not. So when we're describing the panel, we talk about some of the limitations, and one of them is that everyone would be represented. But I think, with 10 to 12, you have a diversity of opinions, diversity of experiences, when you can still have a meaningful conversation and people can feel like they were really involved. I don't think the goal is not necessarily representative of the population, but you want a diverse panel that might sort of reflect the diversity of the population that you're aiming to serve. And, we actually, I show the slide of canvassing, and I've shown it many times. We actually just canvassed one day. We made the t-shirts, we went out for one day, we canvassed, and that was the way we recruited most of the panel members. We did try other methods, like we actually did random digit dialing. So we purchased a list of phone numbers for people living in Toronto from one of these telemarketing companies. I was curious to see if my own phone number was there, it was not. And we sent out letters also to people living in the catchment area of the hospital. We did engage with a small number of individuals through those methods, but the vast majority were contacted through canvassing. So the reason I mention that is just because it's not very difficult to do. I mean, it literally took place in one day. So yeah, sometimes people say, oh, it might be difficult to engage with those people, or are those people going to engage, or they are difficult to reach. I think that those would be terms I would avoid, describing a population as difficult to reach, because actually, if you put on your shoes and go out and talk to people, you have reached them. Some interesting issues come up when you're thinking about a particular condition, like whether or not you want people to have personal experience of that condition or not, or family members of people who have the condition. Maybe one general response would be, let's maybe try and use some of the same standards that we would use for our colleagues as we use when we're thinking about how patients or family members are engaging in the process. Researchers and clinicians, they all have their own views and their own experiences and their own way of doing things that's born out of their experiences. And when you have them on a panel, collaborators on a research project, sometimes clinicians or individual researchers try to have their view prevail, or some doctors spend a lot of time talking about their own experience, even though it's not really relevant to the decision being made. So when a patient does that, we shouldn't say, oh my God, what is this person doing? She's just talking about their own experiences, because doctors do that all the time. I remember actually, before we had our first meeting, there was another researcher who had all kinds of questions. And they were about things like, what if the patients show up late? Because, they're not used to attending meetings, or what if they don't dress appropriately? I mean, what about doctors and researchers? How often do your colleagues show up late to meetings? So it's not let's just calm down. If we use the same standards, we'd be totally okay with people. Maybe I'm not dressed appropriately today. We were just talking about the lack of ties here in the room. At times we met every 2 weeks. That was probably the most frequently that we met. So that was when we were really hashing out the proposal. We wanted to meet frequently so people wouldn't sort of forget the discussion. At other points in the project, like when we were conducting the trial, there was less need for input, and so we would meet every 3 months or so. In terms of keeping people engaged, I think the number one thing was reporting back on what you had done after the last conversation. So at the beginning of every meeting, doing a little recap, one, to remind people what we had discussed, but mostly to send the message that we listened, and you asked about this, and we made this change, or we looked into it and we realized we couldn't make that exact change, so we did this instead. That's, I think, the main reason that people came back. Yeah, by guidance we meant making decisions. So that's the thing that we were clear about. Maybe that would be the number two in terms of why people came back, is I think we were clear about what the group was doing, and it wasn't a focus group where people could express all kinds of views, and then at the end someone else would decide how to interpret those and what actions to take. It was a venue where decisions were made. So that's why we wanted to avoid the term advisor or advisory committee. And I think people just kind of had a negative reaction to the word committee. They saw it sounded too academic and fussy and arrogant. So we called it a guidance panel. I mean, I actually remember we had a particular meeting where there was a discussion about which journals we would submit the first manuscript to. And, researchers were all excited about the results and listed some journals. And I remember the community guidance panel members saying, never heard of any of these. And, we really don't care. And they even asked, so is it more likely if it gets published in that journal versus that journal to result in policy change? And I think the answer is definitely not. It doesn't make a difference, really. Yeah, I think some of these discussions are maybe more interesting to researchers about which journal. But other discussions about how do we get this in the hands of decision makers? What is the main message? How do we pair the boring kind of dry quantitative results of the study with the stories in order to foster change?
Interesting bit of reflection about how our universities, us, use the impact factors in those numbers when really they're not having any impact. But so much weight is put on them for a whole host of reasons. But I really want to thank Nav for his presentation today and the work that he's doing and leading us down